cytogenetic and molecular testing, we'll touch on some of this when we talk about the data. So I do want to highlight that CLL can undergo clonal evolution throughout the disease course. It is suggested at treatment to perform these tests, which I do think is important, but it doesn't determine the decision to treat or not. That's really based on our IWCL clinical criteria. We'll talk today about IGHV mutational status, and FISH testing is also important. To test for TP53 mutations, you do need to do molecular testing with methods such as next-generation sequencing to see if a mutation is present, because you can have both a mutation as well as a deletion in the other allele of P53. So as we look towards the data, I just want you to recall that in general, IGHV mutated disease is more favorable risk than unmutated. There are some exceptions to this, including a portion of the IGHV 321 family called subset 2 does portend more aggressive disease biology. P53 aberrancy, either a mutation and or a deletion of the P53 gene, is associated with worse outcomes in CLL patients. Looking at genetic testing survey results. So which of the following do you routinely assess risk in a patient with relapsed refractory CLL needing next treatment? So just looking at this, I want to highlight here deletion 17p, IGHV mutational status, and TP53 mutational status. These really are the tests that are critical to perform prior to treatment initiation, both in the frontline and certainly in the relapse setting as well, to give a sense of prognostic implications. And most of the group is already testing these. Dr. Coombs is going to talk about BTK testing, which isn't standard of care right now, but is an emerging kind of area. How often do you perform molecular or cytogenetic testing, so FISH and NGS testing, prior to selecting therapy? Most of the audience here is doing it always or often. There are some people doing it never. Some of this depends on access to treatment. So for those who'd answer never, there was some issues with patient affordability or reimbursement for it, depending where you are. This respondent was outside of the United States. Sometimes the test itself is not available, and there's no access to the testing. So that highlights another unmet need for our patients. So in 2025, therapy initiation really does remain guided by IWCL criteria. And before we talk about relapsed CLL, at each stage, I think it's really important to know, who needs treatment for the disease. And so there really has to be a reason to need treatment. And this is really because early intervention studies in asymptomatic CLL to date have not shown any overall survival benefit. So this is a CLL 12 study, which is ibrutinib versus placebo, and there was no overall survival difference between the two groups. There is some ongoing research. I do want to highlight this ongoing study. If you do see patients in the clinic, I'd encourage you to reach out. Dr. Deborah Stevens at University of North Carolina is leading the study in SWOG. I know Dr. Coombs has also been involved, and we have this study open at my center as well. But it's open across the country, and this is for newly diagnosed high-risk CLL. This protocol, if it was now within 18 months of the diagnosis, if patients have high-risk features defined below, so complex cytogenetics or CLL IPI of 4 or more, it's an early intervention of venetoclax obinutuzumab. At the control arm is at standard IWCL criteria, but this is looking for high-risk patients, whether starting therapy earlier will make a difference in survival.
So our first patient case is Mrs. Blanchard. She's a 58-year-old fit female with relapsed refractory CLL. Her medical history is that she's postmenopausal, no other significant medical problems though. She was initially diagnosed with stage 1 indolent CLL and was doing a watch and wait approach. Her prognostic markers included del 17p noted on FISH. She also had unmutated IGHV and a complex karyotype. She was 54 years old when she actually got her first line of therapy. So this was with ibrutinib plus rituximab for her CLL. However, she had intolerance to the regimen due to arthralgias and ultimately discontinued after 6 months, despite dose reduction. And she progressed shortly after receiving her second line of therapy, which was fixed duration venetoclax with the CD20 monoclonal antibody. So now she's coming to our clinic with some current symptoms of night sweats, fatigue. Her performance status, fortunately, is still good at a 0. However, her subjective symptoms include the fatigue and weakness. She does express the following preference, which is, hey, doc, I don't care. You tell me what to do. Here are the responses from our panelists that did the pre-survey on what therapy they would select for this patient. So the answers were kind of all over the map, which is interesting, of course. But 5 of the 25 selected acalabrutinib, 7 selected zanubrutinib, 9 actually selected pirtobrutinib, 2 selected venetoclax-based regimen, and 2 said clinical trial. So with that being our case, Dr. Thompson, what are your thoughts, and maybe what would you think about for her?
I want to highlight one really key point. So when you're thinking about therapies, I always think about why they discontinued the prior therapy. So she got ibrutinib or rituximab, but she was actually intolerant due to arthralgias and only got 6 months of therapy of that. So she actually didn't progress, it sounds like, during treatment with the covalent BTK inhibitor, which is a really important distinguishing point. It sounds like it was kind of shortly after, but not actually on treatment. Now, she did progress shortly after venetoclax, anti-CD20, and if it's less than a year, I'd want to switch classes in that case instead of doing something like venetoclax retreatment. I think there's a couple of reasonable options on the slide, and you saw that reflected in the survey results. Certainly, if a patient discontinues ibrutinib for side effects or intolerance, you can go to a second-generation BTK inhibitor like acalabrutinib or zanubrutinib, and there is prospective data to support that. A lot of patients, there's clinical trials that have shown that patients actually can be re-challenged with the covalent BTK inhibitor class and not have recurrence of this same side effect. And I'm sure you've seen that in your practice as well. I think pirtobrutinib is an interesting one. I'm curious to know your thoughts on that. There are data, and we're going to review some of that, I think, in the presentation from the Bruin study, where those patients were covalent exposed but not necessarily refractory, and they do respond to pirtobrutinib. I tend to try to re-challenge the covalent BTK inhibitor first and exhaust that class, but it certainly is an option, especially after prior ven exposure and covalent BTK exposure to pirtobrutinib. What do you think about that?
Yeah, I mean, to speak specifically to this case, I would favor the use of a covalent BTK inhibitor. I think Acala and Zanu are both great options. I mean, I think if you switch the case around and she's 88, I think it may not matter because the next line of therapy could be your only line. But I think in someone this young, and this is quite young for CLL, I'd much rather just feel like I've totally exhausted the class of covalent. So I essentially agree with everything you said.
Yeah, the other thing I'll bring up, just because this is a really high-risk case, is that, so we have P53 absence or deletion 17p, IGHV unmutated complex karyotype. I think that's an excellent point. It's a younger patient. So we're really, hoping in CLL, we're thinking about the immediate therapy, of course, but also sequencing and always thinking about the next step. So anytime you have a patient, I think, with covalent BTK inhibitor exposure and venetoclax, yes, she hasn't exhausted the covalent BTK inhibitor, but after that, this is one of the patients, if she does start to have progression on the covalent BTK inhibitor, that I would think about additional options, not clinical trials, of course, but also CAR T cell therapy potentially. And I think we'll hit on some of that data later in the presentation.
Totally. So I think that's a great discussion of our first case. I'm going to hand it back to you to do case 2.
All right. So our second patient is a 70-year-old man. He has moderate fitness. He has some other past medical history. So a history of hypertension, currently controlled on metoprolol. He has a family history of prostate cancer. and was initially diagnosed with CLL and managed with active surveillance. He also has deletion 17p on FISH, IGHV unmutated complex karyotype. So this is really the highest risk patient. Deletion 17p does become more common in the relapse setting. In the upfront setting, it's about 5 to 10% of patients have either deletion P53 or deletion 17p and or P53 mutation. So it's a high risk subgroup, but small in the frontline setting. That number kind of increases as you go on. So at age 65, this was, years ago, he received bendamustine rituximab for his CLL, and then relapsed 3 years later and was treated with ibrutinib. He did have atrial fibrillation during treatment with ibrutinib. So currently having night sweats, fatigue, and ECOG performance status of 1. So he will say for these purposes that he discontinued the ibrutinib after atrial fibrillation, and he needs he needs treatment now given symptoms. He's retiring this year and very interested in traveling, and so we're keeping that in mind and keeping the regimen in mind. So here are the survey answers here. We have acalabrutinib, zanubrutinib, pirtobrutinib, and then venetoclax-based regimens. And I'm just going to go back to that was over the most popular answer. I'm going to go back, followed by zanubrutinib. I'm going to go back to the case and kind of see Callie's thoughts here on how she would approach this patient.
So I'm glad you pointed out, we have 2 cases with 17p. It's not that common in CLL in the front line. It can be more common in the relapse setting. So maybe he didn't have that at the beginning, and then it kind of arose in the setting of BR, inducing that selective pressure that is more permissive for the growth of these high risks. Maybe it was a subclone that was undetectable. I think it is a case where you probably have a lot of right answers. So I actually don't feel that any of the answers that were given are wrong per se. What I would think about with this patient is his preferences. So if he's retiring and interested in traveling, I actually really like venetoclax, but if he wants to go on trips and isn't going to be able to do, the busy schedule at the beginning of venetoclax, maybe he would actually prefer to just go on another pill-only therapy, which in his case, once again, he got ibrutinib in the setting of an AE. Assuming this wasn't like life-threatening AFib, and it was just, stopped, and maybe he could have been dose reduced or just switched over, I think we could still do that now. And so I might actually still favor a covalent BTKI in him, but one of the better tolerated ones. And I'll actually be going through the data on AFib and how you actually can switch in the setting of that AE.
Yeah, absolutely. I think this just highlights again, when you have someone with prior therapy exposure, did they discontinue for an AE and they might still be responsive to the class of medicines, or was it that they were progressing during treatment or shortly thereafter? So we're going to go to our third case here.
Okay, I have a sweet spot for the older patient. So I'm happy to present Mr. Campbell, who looks super cute, 81-year-old frail man with relapsed refractory CLL. His past medical history is notable for hypertension, apparently controlled on furosemide, type 2 diabetes, controlled on metformin, and he also had previously been diagnosed with BPH. He was diagnosed with stage 3 aggressive CLL, IGHV unmutated, and he again had del17p and del11q on FISH. He relapsed 6 months after his first-line therapy with BR, so maybe the 17p was there all along because he had a terrible response to BR. Then he received acalabrutinib, but relapsed 2 years later. His current symptoms are lymphadenopathy, and at least on exam, you can palpate 2-centimeter lymph nodes in his groin. He only has a mild degree of lymphocytosis. His labs, though, suggest he likely needs treatment, given that he's anemic, hemoglobin of 10. He also has subjective symptoms of fatigue and a little bit of nausea. And when I talk to him about his preferences, he says, hey, I am concerned about future relapse, but I would really prefer not to travel to the hospital. So let's see what choices were selected. The most common answer is pirtobrutinib, which was selected by 72% of responding individuals. 20% selected ven-based regimen, but I actually like the person who selected other. They said, hey, I might test this person for Richter's transformation. So Megan, what are your thoughts?
Yeah, I think, this was highlighted in some of the sessions yesterday for CLL. When you have a patient who's higher risk, cytogenetic molecular features, and progressing during treatment with a covalent BTK inhibitor, especially 2 years, which is on the shorter side, even with the deletion 17p, you really do want to think about that. We have a nodal presentation here. The patient has symptoms. This is an appropriate time, I think, to do a PET scan to rule out that there's Richter's. And if you do see any higher avidity lesions on the PET, then you would do a biopsy of the most avid accessible lesions to do that. But I agree. I think there's many ways to go, highlighting the complexity of CLL now in the relapse setting. I do think, as we discussed before, there's data for pirtobrutinib here, and there's also data for venetoclax as well.
And I'll go through all of that in my presentation. One thing I would like to point out is for the person who chose PET, definitely a very reasonable approach, but never rely on just the PET results. There's actually been data in the novel agent era suggesting that sometimes you can see higher SUVs in patients progressing on novel agents, but upon biopsy, they're not. It's not as predictive for Richter's, and so that biopsy is still key. So for sake of argument, let's say he definitely didn't have a Richter's, and what would you have chosen?
Yeah, I think this is definitely one of those shared decision-making cases. I do think venetoclax has perhaps a longer track record here, but I have used pirtobrutinib in these situations as well. I will say it's not the label if they haven't had prior venetoclax, but it is listed in the NCCN guidelines, so often it is available. And it does have an advantage, I'd say, in bulky disease. So if say he did the imaging, he's got a nodal mass in the abdomen that's like 9 centimeters, his lymphocyte count is now above 20, to 25, you got a high risk tumor lysis syndrome. He might have to go to the hospital actually for his venetoclax, whereas pirtobrutinib doesn't have that TLS risk. So it's really a discussion of the patient, what things look like logistically, and either pirtobrutinib or venetoclax is reasonable. All right, so I'm going to go through a little bit of the guideline informing care and how we think about CLL. We're not going to spend a lot of time on initial treatment, but we do need to review kind of setting the stage, because the initial treatment does affect later lines of therapy really for decades to come in some of our younger CLL patients. So we have covalent BTK inhibitors, acalabrutinib and zanubrutinib are now preferred, and we'll go through some of that data that extrapolating from the relapse setting. There's no head-to-head comparison of acalabrutinib or zanubrutinib. Then there's fixed duration venetoclax obinutuzumab for a 1-year fixed duration based off the CLL14 trial. We now have NCCN listed, but not FDA approved at this time, acalabrutinib and venetoclax doublet therapy, as well as acalabrutinib, venetoclax, and obinutuzumab triplet therapy based on the results of a study called the Amplify study. It will highlight this study did not include patients with deletion 17p or p53 mutation. There's some data for the triplet and p53 aberrancy from a single arm study of AVO. That's a smaller study, but this is entering the initial treatment selection for patients. And there's no randomized data really to compare BTK inhibitors versus venetoclax or continuous versus fixed duration currently. There are studies planned where we'll have some of this data. So this is where the shared decision-making component really comes in, as well as your evaluation of the patient's disease status. So patient preferences with continuous versus fixed duration therapy, logistical considerations, particularly with the venetoclax ramp-up, come into play. Comorbidities are important. So if they have a bleeding history or atrial fibrillation history, depending on the other disease features, that might steer you more towards venetoclax. Renal dysfunction, you can give venetoclax with renal dysfunction, but they are higher TLS risk, so there's some additional monitoring sometimes that is needed. And then disease features, the molecular and cytogenetic characteristics come into play a bit. And then also, as I was discussing, this is relevant to all settings, tumor bulk and tumor lysis risk when you're thinking about BCL2 inhibition. So this is just looking at a brief glance. It's looking at cross-trial comparisons. So really, I do want to caveat that these are different patient populations when we do this. Not randomized data, but it gives you a sense of what some of the 5-year progression-free survival marks for these groups are. And there does appear to be some difference with IGHV mutated versus unmutated, particularly with fixed duration regimens. With continuous BTK inhibition, we don't see quite as much difference between those molecular subgroups. So let's talk a little bit more about relapsed CLL and thinking about how we manage patients in the clinic. So treatment of CLL after prior chemoimmunotherapy is something we do commonly encounter. I mean, I have patients I see in the clinic, they might have received their first treatment in the 90s, and now some of them have had targeted agents since. Then there's some patients who have a really good response initially to something like BR, FCR, 5, 6, 7 years, but then need their first targeted agent. So it looks very similar, if this is the case, to the frontline setting, even though they're in the relapse setting. You want to think about what the prior treatment-free remission was if they were treated with fixed duration treatment as well. And so in the relapse setting with venetoclax, what I'll highlight, what's different here, is that the data really is with rituximab. However, obinutuzumab does have data from the CLL13 trial as well as CLL11 that it appears to be a stronger antibody than rituximab. Many of us in the United States do extrapolate from these results and do use venetoclax and obinutuzumab in the relapse setting. The duration of therapy, I think, is a little provider dependent because there's some retrospective data here. I tend to follow the 24 cycles like the Murano study and substitute the obinutuzumab, but I think that's an area for further discussion. Here's the Elevate-RR trial design. This was the first randomized covalent BTK inhibitor study, and I'll just highlight here, it was acalabrutinib versus ibrutinib. The patient population is important. Patients did have to have deletion 17p or deletion 11q, which was a higher risk patient population in the chemoimmunotherapy era for sure. And you'll see the exclusion criteria there, including warfarin, which is contraindicated with BTK inhibitors. So just looking here at the progression-free survival curves, there was no difference with a hazard ratio of 1 between ibrutinib and acalabrutinib. Overall, median progression-free survival was 38 months in this higher risk patient population, a median of 2 prior therapies with higher risk cytogenetic characteristics. Here's the Alpine study, which is a head-to-head comparison of zanubrutinib versus ibrutinib in relapsed CLL. This was a little bit of a different population than the Elevate-RR study, so only 1 prior therapy median. They did not have the same cytogenetic restriction for the patient population. Here you see that there was a PFS difference favoring zanubrutinib over ibrutinib, with the median PFS not reached for zanubrutinib. Similarly, with respect to safety, which I think is really important data, in general, zanubrutinib had lower AEs than ibrutinib. There's some exceptions to that. Hypertension appeared to be similar, but atrial fibrillation, atrial flutter was at a lower rate with zanubrutinib than ibrutinib. And really, these 2 studies really form the basis for us using the second-generation covalent inhibitors. I'm going to briefly introduce pirtobrutinib, and then Callie is going to go through this a little bit more. But pirtobrutinib is a highly selected non-covalent BTK inhibitor, so it binds reversibly to the BTK target as opposed to the covalent inhibitors, which bind irreversibly. This is now FDA approved for the treatment of CLL after prior BTK inhibitor and venetoclax, is NCCN listed after a covalent BTK inhibitor. And this is the phase 1/2 Bruin study. You'll see this looking at all patients with prior covalent BTK inhibitor. At a median follow-up of 28 months here, you have a median PFS of 19 months. Only 2.5% of patients discontinued for adverse events, which for a BTK inhibitor is a very well-tolerated drug in this at this early time point. And there's also significant clinical activity with a median PFS of 16 months in the BCL2 inhibitor exposed and covalent BTK inhibitor exposed subgroup. And the Bruin 321 study is a randomized phase 3 trial that was recently published of pirtobrutinib versus investigator's choice, a control arm of a PI3 kinase inhibitor and rituximab, idelalisib, and bendamustine rituximab. There was optional crossover in this study, and you had to have had a prior covalent BTK inhibitor. And the highlight of this study is that pirtobrutinib reduced the risk of progression or death by 46%. In this study, you see a median PFS a little bit shorter than the other study of 14 months, favoring pirtobrutinib over idelalisib, rituximab, bendamustine rituximab control at about 9 months. These are key secondary endpoints, and I'll just highlight that the median time to next treatment was 24 months for pirtobrutinib. This really highlights something when you're looking at CLL data. This is an important time point because some patients slowly progress on a BTK inhibitor, and while they meet the clinical trial progression criteria of the IWCLL progression, they might be able to get some clinical benefit actually beyond that disease progression while you're planning the next steps of therapy. And here we saw was about 2 years before they needed to switch treatments. We have a survey question: which therapies have you prescribed for relapsed refractory CLL in the past 6 months? Like all that apply. We've seen a lot of the standard therapies here. So everything represented. A CAR T cell is less, and Dr. Coombs is going to talk about CAR T cell in her section in this next part of the talk. I'm going to hand it over to her now to kind of take us through that data.
Okay, thank you. So I'll be talking about the evidence-based treatment considerations for treatment selection and sequencing. Dr. Thompson talked a lot about the post-chemo setting. However, we have a lot of patients who are now even getting novel agents in the frontline setting. So what I'm going to speak about is what to do in the relapse setting, but of course we have to base that on what the patient got previously. And so the first category of patients is patients who receive BTK inhibitors in the frontline, which is probably the biggest bulk of patients that encounter me in my clinic in the relapse setting, just because of how frequently BTK inhibitors are used in our country and especially in the community. So as we've already stated, the reason for discontinuation is hugely important. If a patient had intolerance, I generally am going to favor switching a patient over to an alternate covalent BTKI. However, if they progressed on the drug, you do need to switch class, whether that's to venetoclax, which is supported by the current FDA label, or over to pirtobrutinib. Now, technically speaking, not FDA approved, but it is in the NCCN guidelines. So that is something that I've done on a case-by-case basis. So to highlight the data to support switching in the setting of intolerance, this has been well studied for patients who had ibrutinib intolerance and then switch over to acalabrutinib. The highlights of the findings from the studies that have included patients with ibrutinib intolerance are that the majority of time patients are going to experience improved tolerance when switched over to acalabrutinib. Specifically, that ends up being about 3/4 of patients that don't have any recurrence of the side effect that they had on ibrutinib when they switched to acala. However, a subset can have recurrence of the side effect either at a lower grade, meaning less severe, or rarely the same grade. You can also do the same thing with zanubrutinib. And so zanubrutinib has been studied not only in the setting of ibrutinib intolerance, but also acala intolerance. And luckily, the findings are actually pretty similar, making it easy to remember. And so both for patients with ibrutinib intolerance events and acala intolerance events, we see roughly the same thing, where about 7 out of 10 patients are not going to have a recurrence of the side effect that led them to the study when treated with zanubrutinib. And zanubrutinib is able to provide disease control in almost all of the efficacy evaluable patients in this study. So kind of the newest study looking at covalent BTKI intolerance is the subset of patients from the phase 1/2 Bruin trial. So as Dr. Thompson showed you, this trial was a huge study, almost 800 patients. To kind of dive down into some of the subsets that we're going to look at, around 600 had prior BTK inhibitors. And of those with prior BTK inhibitors, 127 of them had prior BTK intolerance. And so the paper published in Hematologica this year looked at the experience of patients that entered the Bruin trial with BTKI intolerance to see how did they do when treated with pirtobrutinib. So these are the recurrence or lack thereof recurrence for the side effects that brought patients into the Bruin study when they received pirto. The dark blue is when patients had no recurrence of their side effect. And so I'd like to highlight AFib specifically. There were 30 patients who participated in Bruin that had AFib as a reason for stopping their prior covalent BTK inhibitor, and 93% of the time the AFib did not come back. However, when patients entered the study with neutropenia, it looks like that was less successful, where 2/3 of the patients that came in with neutropenia did have that recur when treated with pirto. So I do think pirto is an effective strategy. I would usually consider it after I've exhausted the covalent class for most patients, but I would definitely keep that in mind as an option for patients that really favor that all-oral approach. And here's the progression-free survival for patients that entered the Bruin study in the setting of covalent BTKI intolerance. The median progression-free survival is 28 months. So we can also use venetoclax in the post-covalent BTKI setting. Venetoclax is an amazing drug. Murano, the PFS is like years and years and years. But realize Murano, only around like 2 to 3% of patients on the Ven-R arm had a prior covalent BTK inhibitor. So again, that PFS is a post-chemo PFS. How does Ven perform after a covalent BTKI in a prospective setting? Well, the data are actually pretty scarce. So here's a 91 patient study of actually very high-risk patients, 4 median prior lines of therapy, around half at 17p, where all patients were administered Ven as a continuous monotherapy. And so Ven is effective post-covalent BTKI as a monotherapy. The overall response rate is 65%, and the median PFS is around 2 years, specifically 24.7 months. This was further supported by the phase 3b Venice study that once again used venetoclax monotherapy in the relapsed refractory setting. This study included patients who were naive to a B-cell receptor pathway inhibitor, which was the bulk of the patients included in the study, but they also had a BCR inhibitor pre-treated group, which was 67 patients. And so these were mostly post-ibrutinib patients, but there was a small number of patients who had previously received idelalisib. And the progression-free survival is actually strikingly similar to that 91 patient study I showed you, where of the BCR inhibitor experience group, the median PFS upon treatment with Ven monotherapy, the PFS is 23.4 months. So once again, right around 2 years. So now let's look at a different group of patients. What do you do with patients who receive Ven in the frontline setting? Well, look, of course, covalent BTK inhibitors are going to be an effective option. Do we have a lot of data to support that? Well, no, because there aren't really that many patients who have received Ven in the frontline that are now relapsing that we now have long-term follow-up on. But there's no reason to think that that approach wouldn't work. And so I think that's certainly reasonable. And that's what I would favor for patients who just had a terrible time with venetoclax. It's not common, but there can be patients with, significant GI toxicity, or dose-limiting myelosuppression that is unresponsive to growth factor. However, for most patients that I give Ven to the frontline, most of them are actually still in remission, okay? But the patients that I would most favor Ven retreatment are the patients who have good remissions. Now, how good is good? I always say the longer, the better. But 2 years has often been thrown out as longer than 2 years. You could do retreatment, and even longer, I would expect better responses. But you should always consider the age of the patient, comorbidities, patient preference, in addition to, how well did they tolerate Ven the first go round. The data for Ven retreatment are somewhat scarce, but they're continuing to grow. So we actually saw a poster at EHA regarding some very early data from this Re-Ven-G trial. It's a very cutely named study looking at retreatment with Ven-G in patients that got Ven in the frontline. Very high overall response rates were seen. However, the data are premature to comment upon how long the responses are going to last. past. So I would like to highlight a study that was led by Dr. Thompson that does have mature follow-up looking at ven retreatment. Now, these are not necessarily second-line patients. So the patients included this study had a median of 2 prior lines of therapy. So kind of the average patient, so to speak, is a third-line patient, meaning they got something in the front line, ven in the second line, and then retreated with ven in the third line, although there, of course, is a variety within the population. So these are 46 patients that underwent ven retreatment. The time between the first ven treatment and the second ven treatment, it's a median of 16 months. So often these patients didn't do that full 2 years between their ven treatments, but you can see high overall responses. About 80% of patients are responding to the second course of venetoclax, and then the responses seem durable, where the median PFS for the second go around with the ven-based regimen was 25 months, supporting the ven retreatment approach. So our last group of patients perhaps is the most challenging, patients who have had both covalent BTK inhibitor and ven exposure. It's important to think, are they just double exposed or are they truly double refractory? Double exposed patients have more options. So if they're covalent BTK intolerant, of course, you can just try a different covalent. If they've had ven, but they had a nice remission, you could retreat with ven. Double refractory, though, we only really have 2 favored standards of care in the NCCN guidelines, also supported by their FDA labels, which is pirtobrutinib and liso-cel. Pirtobrutinib leads to high overall response rates, 82%, in patients with at least a prior covalent BTK inhibitor. And when we look at the patients who had also had venetoclax, that's the progression-free survival curve on the right of the slide, it has a very good median progression-free survival of around 16 months. So here's a survey question. Have you ever prescribed a non-covalent BTK inhibitor? I was actually impressed to see a lot of our respondents had either currently prescribed it, 28%, or have prescribed it in the past, 28%. However, 42% of our respondents hadn't yet prescribed Pirto, which, I think is also reasonable because these third-line patients are also not that common because of how well our first and second lines work in our setting. And we also see the answers for why our respondents had chosen a non-covalent BTK inhibitor, usually due to prior BTK inhibitor resistance or just the established efficacy. These are concerns related to using a non-covalent BTK inhibitor, which I actually think are all pretty reasonable. And so to highlight the potential for cross-resistance to covalent BTK inhibitors, I'll briefly be able to go through the data. I think that's a reasonable concern, but not one that I'm actively super worried about. I think we need more prospective data. So liso-cel is our other option in the third line or beyond setting. This is the CAR T that's approved in CLL. It was looked at 2 different dose levels. Dose level 2 is the one used for the expansion phase of the study. And the goal of the study was to establish a high CR/CRI rate above their null hypothesis. Only 1 in 5 patients attain a complete remission. CR rate was about 20%. When you look at the patients who also did not respond, that's where you can see the median progression-free survival, which is in the black. For the entire population, the median PFS was 17.9 months, but when you focus on the group of patients that meet the current FDA definition, this primary efficacy analysis set that had also had prior venetoclax, the median PFS is 11.9 months, which doesn't look great, but it can be a really great drug for the patients that respond, especially if they get a CR. I think liso-cel's benefit is it can lead to deep and long responses, but only in a small subset of patients. Pirtobrutinib is going to work in most patients with an 80% response rate, but you're not going to see those deep responses. It does offer convenience, though, as a pill. Liso-cel is a bit inconvenient for a lot of patients who may not have access to the specialized centers. And so why do we think about resistance mutations? So first of all, I don't think it's standard of care to send these resistance mutations, but I do think it's very important to continue to study this in the research setting as it can inform the best sequencing approach for patients with BTK inhibitors. The most common resistance mutation is the acquisition of C481 mutations, which has been well described in ibrutinib, but it also occurs in patients getting acalabrutinib and zanubrutinib. However, there can be these non-C481 mutations. And so within acala-treated patients, there have been these T47I mutations. Within Xanu-treated patients, there's been L528W mutations. And these, are maybe a little bit theoretically worrisome because those mutations are actually the two most common resistance mutations to pirtobrutinib. And so the question has been raised, is this going to lead to cross-resistance of these two agents if one of these more exotic non-C481 mutations arises? I'd say it's potentially concerning, but not overly alarming in my viewpoint, because most of the time when these mutations do arise, well, number one, they're not that common, but number two, they often are subclonal. And so you can actually still see responses to pirto in patients who have these mutations, assuming they're not fully clonally dominant, but we do need a lot more data to understand the true implications of that. So I think patient input is probably my most important factor when I'm thinking about a therapy, and that's what our respondents said as well when we asked about how important are the following factors in guiding your treatment selection for your patients with relapse refractory CLL. However, of course, there's a lot of other important factors. The second most common answer is age, frailty. Third most common, TP53 mutation status. So you can't hone it down to one single important thing, but I do think patient preference and goals is just hugely important in CLL, given that we have so many effective therapies and they're all honestly just kind of different from one another. The last section is multidisciplinary and interprofessional care and management and adverse events. And so our survey asks which adverse event associated with BTK inhibitors has been difficult to manage in your patients with relapse refractory CLL. I agree with the audience here. I hate AFib. I hated cardiology my whole life. My whole medical life. I didn't have it myself. It's just a big pain to deal with. And it's a problem in patients with BTK inhibitors because now they have to go on a blood thinner. These drugs already cause a risk of bleeding. And so, I totally agree. Infections is the other common highly selected answer, which also can be an issue. What I'd like to point out from acala specifically is the safety data as compared to ibrutinib, where it leads to not only lower rates of AFib, but also significantly lower rates of hypertension. The bleeding rates, there is lower any grade bleeding, but the major bleeding you see is probably not that different. And I think bleeding is honestly pretty similar between all the covalent drugs. Xanu also is a well-tolerated drug, but I think the most important data set is when Xanu was stacked head-to-head against ibrutinib. And I'd like to highlight much lower rates of AFib. This table quotes the grade 3 or higher events, but there was also a significantly lower rate of any grade AFib with Xanu. And overall, just a much improved cardiac safety profile. However, it does not have lower rates of hypertension, so that's just something to think about. Better tolerated in general, though, is evidenced by lower rates of discontinuation or dose reduction due to toxicity. So how do we manage AEs? Well, the best thing is to prevent them. So if you have a super high-risk patient, maybe they just shouldn't go on a BTK inhibitor. However, if the BTK inhibitor is the best drug for that patient, especially in a high cardiac risk patient, I would encourage multidisciplinary collaboration by having patients see either their cardiologist or a cardio-oncologist if you have access to that, because a patient who's optimally medically managed from their cardiac comorbidities is likely going to have a better experience on a BTK inhibitor than someone who just has uncontrolled comorbidities. And also sometimes I learn from cardiologists, hey, they actually don't need dual antiplatelets anymore. Aspirin alone is okay, and maybe that could decrease their risk for bleeding, et cetera, et cetera. So prevention first, and then next is monitor for the side effects, and then last is mitigate the symptoms should they occur. Here are the pirtobrutinib side effects. Pirtobrutinib is a drug that actually has very low rates of discontinuation, reflecting its excellent tolerability among most patients. However, it does cause a decent amount of neutropenia, so that's something that I would like to specifically call out related to pirto. It's hard to say if it's the drug or maybe it's the fact that these are like 4th, 5th line patients, but I would monitor for the neutropenia in addition to some of the other side effects that can rarely be seen with pirtobrutinib. The AFib rate with pirto is very low though, it's like 2.6%. But the same principle of prevent when you can, monitor, mitigate symptoms. Lastly is venetoclax. These are data from ven monotherapy where the main side effects are hematologic in nature, myelosuppression. And so in order to prevent, monitor, mitigate, I have seen it so many times where patients stop ven due to neutropenia and they haven't even gotten growth factor. And so you can really support patients through venetoclax-based regimens if you monitor but also treat neutropenia if it's going to be dose limiting or a reason to stop the drug. The last section is about a really important topic, shared decision-making, strategies and resources for patients with relapse refractory CLL. So what factors guide treatment selection for your patients with relapse refractory CLL? And honestly, all of these are good answers, but just as I highlighted before, the most commonly selected answer is patient preference and goal. And I think that's the most important to me too, although of course these other things matter, like age, how did they tolerate prior drugs, disease biology markers, etc. So we've all heard the term shared decision making, but what does it actually mean? To me, it means offering patients choices when there are choices that are maybe equally reasonable. And so it's the joint process between healthcare providers and patients based on the evidence-based approach and taking into account the patient's preferences, beliefs, and values. And, a lot of patients really do want to be involved in their care. It empowers them to make decisions. Maybe then they have more ownership about their future. And just to give one example, I have this really nice lady who had been getting her CLL care from someone in the community, very appropriately got prescribed ibrutinib in the frontline setting. However, she had like a horrific rash to ibrutinib. That was not better despite dose reduction. She got high dose steroids. And she eventually just went off the drug after about 3 weeks. And she was somehow able to stay in remission for another 3 years. I didn't know her when she started, but it was before the other second-gen drugs were available. So, they didn't discuss switching with her. And I think her disease bulk was such that maybe she could have not started treatment. I don't know. But she comes and sees me about 4 years later, and her spleen is huge. Her white count's like 200. And, my usual assumption would be, hey, you picked a BTK inhibitor before, maybe you just want a BTK inhibitor now, and now we have a cal and Xanu. But she was like, yeah, what other options are there? And I, of course, discussed with her another option. Hey, we actually now have more options than when you first started treatment. In addition to these other non-covalent BTK inhibitors, there's venetoclax. Well, tell me more about venetoclax. And of course, I shared with her there's a time-limited regimen. She's like, I'd much rather do that. I don't want to be on something indefinitely. And so she did Venoben and has done great with it. So I think it's not wise to make assumptions. And maybe your assumption is correct, but I find often it's totally not correct. And you have to kind of have that conversation with your patient to make sure you do what is best for them, because they know themselves best. We know the data, but they know what they want and what their preferences are. So Dr. Thompson, any other anecdotes to add?
Even in symptom assessment, sometimes you have to do this in history taking. So we're talking about fatigue being an indication for treatment. And being really tough to, there's not like a test or quantitative assessment necessary. We have ECOG performance stats, but it can be really tough. So a lot of times I'll talk to the patient, kind of assess, is the fatigue bad? And a lot of times we talked about other progression signs are coming along, but you'll talk, we can try CLL treatment for this if your workup for other causes has been negative, but there's the potential that it could improve the fatigue, but there's also fatigue side effects. So it's part of the calculus also sometimes in figuring out, is it the right time to start treatment for that indication now, and kind of your history taking and assessment.
So with that, thank you again, also from me for participating.
Do you have a preference for Acala versus Xanu as far as cardiac toxicity?
I would say it's very patient specific because there's really no randomized data for acalabrutinib versus zanubrutinib. There's been attempts to look at those randomized trials, the Elevate RR, which was the acalabrutinib, and the Alpine study, zanubrutinib, and do these MIAC studies. But I think in the absence of a randomized trial, you kind of just have to go on patient-specific factors. I will say for hypertension, it appears to be a little bit less, I think, with acalabrutinib. So if someone has poorly controlled hypertension and they're going the covalent route, I may lean towards that. On the other hand, maybe the AFib looks to be a little less percentage-wise with zanubrutinib, but I've definitely used both in either circumstance. And sometimes other disease characteristics come into play. So like neutropenia, I find to be a little bit more maybe with zanubrutinib. The headache occurs with acalabrutinib. So it's still a little bit of a toss-up. The Xanu does have the flexibility of dose reduction because it's 2 pills in the morning, 2 pills at night, or there is once a day dosing. And so there's a Cala I have dose reduced, but that's not on the package insert actually. It's 100 milligrams BID and there's not as much flexibility. So it's a little bit of a toss up and I prescribe both.
I'm a second year resident, so excuse my questions.
No.
But, if we're seeing a lot of side effects with ibrutinib, why can't we start with Xana or acalabrutinib?
Yeah, so I actually, for new starts, am not using the ibrutinib anymore. And it's an option, definitely has great clinical activity. It was the first BTK inhibitor. But because of that data from the randomized trial showing the better safety profile with acalabrutinib and zanubrutinib, and then actually there's better progression-free survival in the relapse setting with zanubrutinib than ibrutinib, I tend to use either acalabrutinib or zanubrutinib. Now, there's many patients who have been on ibrutinib for a long time, maybe are tolerating it. Some of the toxicities, one thing we didn't talk about, are cumulative. So you can have hypertension's a big one I see. So like 5 years into ibrutinib, you can get new onset hypertension that can be a little difficult to manage. I have switched patients from ibrutinib, for example, to acalabrutinib in that setting, and the hypertension has gone away. People have been able to drop antihypertensive meds, so it's something to kind of consider. But it's a good point. If available, I would start with acalabrutinib or zanubrutinib and not do the ibrutinib.
So, Dr. Thompson, my question would be like, which patient would you consider doing a quick cytoreduction with CD20 on top of Acala or Xana? Like the acalabrutinib trial that had 3 arms, had a GO plus acalabrutinib arm as well, and seems to be as efficacious. So, like in some patients who have a lot of disease volume, especially in the lymph node, I tend to add GO on top of, especially for the first 6 months or so, and then take them to acalabrutinib indefinitely. Is that a good plan, or do you have a patient that you would do a CD20?
Yeah, that's a great question. It comes up a lot. What he's referring to is the Elevate treatment naive study had 3 arms. There's acalabrutinib obinutuzumab with the 6 months of obinutuzumab. You do a 1-month lead-in with the BTK inhibitors, how the study was, and then 6 months of obinutuzumab, or 6 cycles of obinutuzumab. And then there's the acalabrutinib monotherapy arm, and then there was the chemoimmunotherapy arm. And the acalabrutinib obinutuzumab arm had improved progression-free survival, actually, compared to the acalabrutinib arm. But I think not every patient, there is added toxicity definitely with the obinutuzumab in terms of infection risk. That's not just during the treatment, but we know, like with obinutuzumab, we really learned a lot during the COVID pandemic looking at things. Sometimes patients don't recover their B lymphocytes a year plus, and some 6 months was kind of what we used to think, but actually looking at it, I think it's closer to a year plus. So it is immunosuppressive, so you kind of risk benefit. So I don't actually commonly add it. One case where I do is in patients who have autoimmune cytopenias. A lot of times I'll actually start with an anti-CD20. Sometimes I even start with rituximab, like if they have an ITP or autoimmune hemolytic anemia that is especially not steroid responsive. Sometimes I'll do a rituximab lead-in. You could use obinutuzumab as a little harder with the cytopenias in my experience, so I'll do rituximab lead-in and then add the BTK inhibitor, and sometimes I'll do the obin after that based on the Elevate TN with acalabrutinib. The one group where it hasn't been shown to be effective in terms of improved progression-free survival is TP53 aberrancy. So you would think maybe higher risk patient, you should add it, but actually when you look at the Elevate TN subgroup, deletion 17p or p53 mutation did not have a PFS benefit. So it's definitely an option. I discuss it with patients, sometimes younger patients, but a lot of times you're choosing the BTK inhibitor because they don't have access to obinutuzumab. The infusion reaction is less when you do the BTK inhibitor for a month and then give obinutuzumab. I don't know that anyone's quite figured out why that is, but it's disease bulk decreasing and maybe some anti-cytokine effect of the BTK inhibitor. I'm not sure, but I think it's a very reasonable strategy, particularly if you have a higher disease burden patient and maybe not as much concern for infection risk.
Relapsed refractory setting, do you do PJP prophylaxis?
That's a really good question. So the question was about prophylaxis and opportunistic infections, including PJP. I don't do it across the board on everyone. If a patient has a history of PJP, I do usually keep them on the prophylaxis. And then it depends a bit on their infection history and prior therapies. So if they had prior like fludarabine therapy, maybe they got CAR T cell, that's like a whole guideline recommended thing to do. If patients had other fungal infections in the past, I have them on prophylaxis often, but it is a case-by-case basis with BTK inhibitors. And it's something like we've discussed and revisited. In the early clinical trials of BTK inhibitors, we did see, many PJP, but also other like actual fungal, invasive fungal infections. So that's the other prophylaxis to consider. With PI3 kinase inhibitors, which aren't used as much, so we didn't talk about it much, definitely everyone needs to be on PJP prophylaxis. And I recently had a patient with PJP pneumonia on first line ven-oben just due to their immunocompromised nature. So it does come up. I think we didn't talk about checking immunoglobulins is really important. So if a patient's IgG levels are less than 500, 600 range, and they have a history of recurrent, especially sinopulmonary infections, you can give prophylactic IVIG. And I think in the relapse setting, that's really important to kind of think about those supportive care things. And then for invasive fungal infection prevention, the other thing I keep an eye on is the neutropenia. So a lot of times you can use growth factor, say zanubrutinib has neutropenia or pirtobrutinib, use growth factor to kind of maintain their ANC, even before going for a dose reduction sometimes.
The downstream PCOG2, who you would be worried about that mutation being resistant to pirtobrutinib?
That's a great question. So I actually enrolled a patient. He was one of my favorite patients at UNC on the Bruin trial who had like 4 different PLC gamma 2 mutations. And I remember when the trial came up, I was like, I wasn't that enthusiastic about offering it to him because I was like, why would this drug work in you? So I gave him something else standard of care that he progressed on, and then it was the only trial I had open for him. I put him on, and he responded. And, so I think the thing to think about with PLC gamma 2 mutations, but also some of these weird non-C481 mutations, is they're often subclonal. So look, is he gonna be on this drug for 10 years and live a merry life? No, like the drugs never work forever, but if it's a small subclone, CLL is generally not an aggressive disease, and so if you can treat the bulk of the clone that doesn't have the mutation, patients can still often get a clinical response. He actually he was one of the Richter's patients on Bruin, so I was not gonna just leave him on and he was young too, he was in his 40s, so I did not just leave him on Perto and see what happened. I sent him to an allo when he was responding, and yeah, he did okay when I left. I don't know how he's doing now because I left 3 years ago. I do get reports back because they know how much I cared about that guy. But anyway, yeah, so that's to answer your question based on anecdotes, which obviously the plural of anecdotes is not data, but I would think about the clone size, which usually is reported nowadays, and the small clones, like, it's not like AML where they're just gonna totally blow up in the course of a month. Like, people can still get some decent duration of response. None of these therapies are definitive. We're always gonna have to think about maybe the next thing, especially for our young patients. But that's why I don't totally freak out. But, if it was like an L528W with a variant frequency of like 50%, I'd be like, well, that may not look good.
What are some of the patients you consider allotransplant?
I think I alloed 4 people at UNC that I can recall. Richter's always, if you think it's a clonally related Richter's, which usually pathology can send some extra tests to figure out if it's clonally related. So those are the bad Richter's. So Richter's gets lumped into like CLL that morphs into, usually a large cell lymphoma, but also CLL patients who coincidentally have a separate DLBCL. So that group, they can do fine. That's the minority, so most of them are clonally related. Those I always send to allo. I think I've only successfully sent the one guy that I shared with you to allo. The rest of my Richters all died. I mean, it's a horrible disease. And then super young patients. So actually Debbie Stevens took over my job at UNC, and one of my other favorite patients, also young, he was 36 maybe when I diagnosed his CLL. Horrible. He was just like the cases we presented, 17P, his complex karyotype was like 4 lines. He had like every abnormality, got frontline ibrutinib, did well. He actually participated on the PERTO-VEN-R study in second line, and he's gonna progress at some point. And he's 30, well, I don't know, he's probably like 41 now. He's similar to my age. When someone's that young, you kind of just see the writing on the wall. So actually, Debbie updated me like a few years later. He had time off therapy, so he probably can get retreated with Ven, Perto, any of the above, but those aren't gonna last forever, and she was referring him to allo, and I obviously totally would support that. So the super young are people that are reasonable, or just people that have exhausted all reasonable therapies. I don't have a ton of enthusiasm about CAR T, however, I probably would try CAR T before allo, because though the response rates aren't great, I do think the toxicity is better. Look, you're not gonna have graft versus host disease for the rest of your life with a CAR T. So yeah, I'd probably try CAR T, then go allo, now that that's available. Have I ever done CAR T? I actually haven't. I've discussed it with some of my patients, but no one wants to do it because the response data just looks so bad. But I think they do that before they do allo, but I just haven't had to get there, at least in the past 3 years.
We saw in our cases, one of the patients, young patient, had like a relapse disease after PR within 6 months, and then they had all the risk factors, and they're pretty healthy. Like I know the combination, like triple combination ABO or something like that, has been studied in upfront. Has it ever been studied in relapse?
Yeah, so that's a great question. So there are studies that have looked at triplets in relapse settings. So there's a study from the German CLL study group called the CLL BAG trial that looked at triplet in the relapse setting, and they did like a little chemo debulking and then the triplet. So there's some data there. It's not standard though currently. There's an ongoing study that the data hasn't been presented yet it's a randomized study of actually pirtobrutinib, venetoclax-rituximab, and then the control arm is the Murano regimen, venetoclax-rituximab. So that's going to be a randomized study in the next, I don't know when it'll read out, but the next few years, hopefully, that we'll have data in the relapse study. So there's small studies, but it's not a standard approach right now. But yeah, excellent point.
The relapse settings, if you're trying to choose venetoclax regimen, when are you adding to venetoclax?
So I'm adding it pretty frequently now, I would say. I think that's an evolving area, though. So venetoclax, as you guys might know, is first, as many drugs are, was first approved as a monotherapy in higher risk CLL. So there's was a lot of data in deletion 17P CLL. So it is studied as a monotherapy, but the pivotal phase 3 study was the Murano study, so it was 2 years of venetoclax and 6 cycles of rituximab. And that is really the FDA-approved regimen in this standard. I have been, over the past probably 2 years or so, substituting obinutuzumab for the rituximab. Because for a couple of reasons. The frontline CLL-13 study had 4 arms. There was a ven-obin arm and a ven-rituximab arm, albeit frontline. And actually, there was no difference between chemo control arm and ven-rituximab, but there was between ven-rituximab and ven-obin versus chemoimmunotherapy. And then there's data, the CLL11 trial, there's some data from lymphoma as well, that obinutuzumab, I think, is a stronger antibody. In the United States, we're fortunate because it's listed in the guidelines, so often insurance will approve it, but most parts of the world, that's actually not the case. And so obinutuzumab can be tricky, I think, depending where you are to do. And I know colleagues pretty much anywhere outside the United States, I haven't heard them being able to combine the obin with venetoclax in the relapse setting. But I usually do try to do that with the aim of probably doing a 2-year fixed duration. But a lot of times patients are progressing around that time point anyways, especially if they're heavily relapsed and high risk.
Are you testing for BTK resistant patients? Is it commercially available?
That's a great question. I'm sure if you ask Meghan, she probably is. I'm like kind of a stingy person by nature, so I don't like sending clonoSEQ. I think it's expensive, and I was telling the other group, like, I don't want to know if someone's 10 to the minus 5 because I want a good result. Like, I just want to know if they're negative 10 to the minus 4, flow's cheaper. Okay, so I'm a little different. So I don't do clonoSEQ because I think it's an expensive test that doesn't necessarily change what I do, but I do like knowing if they're negative or positive, but I just stick to the 10 to minus 4 level. And then I don't always do sequencing. However, I will have a conversation about it with a patient who's progressing on a BTK inhibitor. But look, patients sometimes get bills for these expensive tests, so I don't just willy-nilly send it in everyone, because at least at my institution, we don't have an institutional test that we just kind of like pay for ourselves. But I tell patients, hey, look, this is something we could send. The last patient that I did it in, he's like, I'd like to know, and my insurance, I never get bills, so then I send it. And he had a T481, or he had a C481T, which I hadn't seen a T before. It's usually C481S. I had another patient who that I sent it on. But yeah, I usually have a conversation. Hey, do you want to know? It's not going to affect what we do. I had been sending it to Neogenomics. They have like a commercial assay it's like the BTK inhibitor resistance assay that includes both BTK and PLC gamma 2. But there's a problem with that assay actually, which is it doesn't sequence into the 500 exons. So I don't always send that assay if someone's on Xanu, because it's not going to pick up the L528W. What I've heard from colleagues is if you want to find the 528W, the commercial assay that you can do it is Foundation Medicine. Supposedly, Foundation 1 Heme sequences the entire protein. We do actually have an in-house assay that checks BTK, but it's only the exon that includes like the 400s. It doesn't go all the way to 500. So that's just something to keep in mind. There's not much in the way of commercial assays that I'm aware of that go all the way out to 500. So I did have a patient progressing on an investigational non-covalent BTK inhibitor, and I kind of want to know, does he have one of these weird mutations? So I did send out Foundation Heme on him, and the results not come back yet, but he actually did have a 474I. But that was picked up on our own internal assay that includes I don't remember the name of the exon, but the one that includes like 481, 474, et cetera. The 528's later in the protein.